So we have coagulation factors coming into play. This is a platelet coagulation activity. So the platelet membrane surface acts as a surface for further coagulation sequence to happen or floating sequence to happen. So we'll deal with each step once more, means in the subsequent slides. So first step is called platelet adherence. So in this, actually, when there is an injury to the blood vessel, the vascular subendothelium gets exposed, and so that's a first step. And then to the exposed subendothelium, platelets are recruited. Now, platelets, once subendothelium is exposed, the exposed components of the subendothelium, that is collagen, 1 milligram factor or fibrinogen, all those things, will bind to platelets nearby. Actually, the binding is classically by two types of glycoprotein. One is called 1B9, which actually binds to 1 milligram factor, and the other one is glycoprotein 1A2A, which binds to collagen. So we'll see in this diagram. So this is 1B9 on platelet surface, which binds to 1 milligram factor on subendothelium, and then 1A2A is other glycoprotein which binds to collagen. So these are the two most important glycoproteins on platelet surface involved in platelet adhesion process once endothelium is injured. Now the second step is platelet activation. So once the adhesion happens, calcium, there is an influx of calcium from cytoplasm, from circulation, means from the extra cellular component into the platelet. And once the calcium comes in, there occurs cytoskeletal changes inside the platelet. That means there are platelet granules. So two different types of granules inside platelet. One is called alpha granules, other one is dense granules. Both these granules contains various platelet activating substances. So this is called, means in alpha granules, various components are VWF, platelet factor 4, thrombospondin, fibrinogen, PDGF, like that. And in dense granules, you will have ADP and serotonin. So means once a calcium comes in, from these two sources, substances are released into circulation. That leads to conformational change. So once the substances are released, then we have seen there is another glycoprotein on platelet surface, which is called 2B3A. So that will be staying in an inactive state usually. But once the release of these granular contents happen, there occurs a change in the 2B3A structure. So that once a change happens, the platelet goes to the next step of platelet function, that is called aggregation. So the changed alpha means 2B3A, it's otherwise called alpha 2B beta 3. The changed 2B3A glycoprotein can bind to a fibrinogen nearby, and then so that can bind to one platelet surface. Then there is a 2B3A. Then it binds to fibrinogen. Then that fibrinogen binds to another 2B3A on a nearby platelet. So that process, the entire process is called platelet aggregation. Now that process will be going on happening so that a large platelet aggregate forms. Now, once this process starts, there is more and more platelets getting activated, leading to more and more substance released from the granule, so that the aggregation process happens very, very fast. So the last step is interaction with coagulation factors. So what happens is, after the platelet surface is activated, so there is a change in the platelet membrane phospholipid. So once that change happens, coagulation factor complexes can bind to the platelet membrane phospholipid, and then that leads to further activation of coagulation, leading to proper protein formation. Now let us talk about some of the platelet function disorders. So one is, as I mentioned at the beginning, the most important is acquired platelet functional disorders. So, and one of the commonest scenario where we see platelet function disorders in the acquired state is liver disease. So what can be the causes for acquired platelet disorders? Means in liver disease, what can be the causes for platelet dysfunction? So one is, as there is in liver disease, bleeding can happen because of there is less production of coagulation factors, because we know that liver is the main source of production of almost all the coagulation factors in the body. And with related to platelets, what happens? Liver is also when there is liver disease, there can be reduction in platelet synthesis leading to thrombocytopenia. So that is quantitative defect. And then obviously there will be platelet function abnormality also. That's called qualitative platelet issue. So thrombocytopenia, what are the reasons for thrombocytopenia in liver disease? One is usually thrombocytopenia is not like massive means severe thrombocytopenia. This is usually moderate only, either because of, and the causes can be portal hypertension and splenic sequestration. So that platelets get sequestered in the spleen, so leading to decreased platelet count. And second thing is decreased platelet production, because of reduction in because thrombopoietin is a platelet production hormone with the source of which mainly is liver. So when there is liver disease, reduction in thrombopoietin production happens, so that thrombocytopenia can happen. Then as such, what happens with platelet aggregation liver disease? Because the aggregation can be abnormal and the bleeding time can be prolonged. And one reason is we have seen that for aggregation, fibrinogen is important. And in case of liver disease, there is a reduction in fibrinogen production, so that platelet aggregation can get affected. So impaired platelet aggregation. So that is what happens in liver disease. Now, what happens in patients with the chronic kidney disease leading to uremia? So, in patients with uremia, they can present with ecchymosis, epistaxis, genitourinary or GI bleeding, all because of mainly platelet dysfunction. Usually, quantity of platelets are not affected. And then there are various other reasons also for patients to bleed. One is there can be coexisting coagulopathies in case of uremia. Then many of the time, if patient is on dialysis, just a second.
സാറിന്റെ അവിടെ ഇന്റർനെറ്റിന് എന്തോ ഇഷ്യൂ ഉണ്ട് സാർ. ഹലോ,
Audible? Hello?
can you like, I think if webcam is open, it can be closed because some issue with the connectivity.
No, now am I audible?
Now audible.
Yes. So we'll start. So in uremia, there can be coexisting coagulopathy, and second thing is many of the time, if the patient is on dialysis, they will be on heparin, so that can lead to some bleeding issues. And then there are, because of the uremia leads to generally altered metabolic problems in the body, that can also affect platelet intrinsic metabolic issues, so that can also lead to platelet dysfunction. And then, I mean, these are all proposed mechanisms there, because we know that platelet endothelial interaction is very important for normal platelet function. And in uremia, it has been seen that there can be deficiencies in platelet endothelial interaction. And another point is chronic kidney disease will lead to anemia. And then because of anemia, platelet function can be impaired. So the explanation for that is in case of, because we have seen at the beginning that for a platelet to adhere to the subendothelial collagen, it has to be as close to the endothelial surface. That means in a normal flowing blood, in a blood vessel, platelets are usually present on the periphery of the blood vessel in the flowing blood, so that whenever injury happens, platelet can easily adhere to the subendothelial surface and block bleeding. So that, and one of the force that keeps the platelets towards the periphery of a circulating blood flow is the normal amount of RBC. That means if the RBC count, that means normal hemoglobin is normal or RBC count is normal, that will be keeping the platelets towards the periphery. Now think of a situation where there is severe anemia, and then definitely the RBC count will be much lower. Now that will push more of the platelets towards the center of the flowing blood, so that the normal etching process may not happen. So that is the influence of anemia on platelet function. So severe anemia can lead to impaired platelet function because of the less adherence. Now, there are situations in which we see paraproteinemia or dysproteinemia, like multiple myeloma or Waldenström macroglobulinemia. So that can affect platelet function, leading to platelet dysfunction. And it has shown that this paraproteins or abnormal protein can affect all stages of platelet function, including means whatever stages we have mentioned: adherence, activation, aggregation, procoagulant activity. All the stages of normal platelet function can get affected. Now, another situation, hematological disorder, where we can see platelet function abnormalities. One is myeloproliferative disorders, where we can see both platelet as well as vascular defects, and the patient can present with gingival hemorrhage, gum bleeding, epistaxis, GI bleed, and bruising. And it just means while with the platelet aggregation test, usually in myeloproliferative neoplasms, there is an impairment in epinephrine-induced platelet aggregation, which is a sole abnormality. Now, in this talk we'll be talking about Glanzmann's thrombocythemia, which is, we all know, it's a congenital condition. But there is another condition called acquired Glanzmann's thrombocythemia. So let us see what are the scenarios where we get this. So usually it is an uncommon condition, and it is because of the production of either autoantibodies or allo antibodies to platelet glycoprotein, that is glycoprotein 2b3A. So there are antibodies against this glycoproteins. So we know that what is going to happen is, once these glycoproteins are affected, there is no platelet aggregation happening. So that can lead to platelet dysfunction and bleeding. So in the common situations where acquired Glanzmann's thrombocythemia is seen are, one is pregnancy, which can produce antibodies. Then various autoimmune conditions, example SLE, they can produce autoantibodies against this glycoprotein. And sometimes these agents used in cardiac conditions like abciximab, eptifibatide, which is actually, those are antagonists of this 2b3A antagonist. So that can also produce this acquired Glanzmann thrombocythemia. And the clinical manifestations are exactly similar to the congenital condition. But this also we have to keep in mind, such a scenario exists sometimes. Now, going to inherited disorders of platelet function from a clinical point of view. So one is called means I am talking about common situation, common in the sense that among platelet function disorders, which are the common ones, even though all these are rare. So one is Bernard-Soulier syndrome. Because of this is classically because of the deficiency in glycoprotein 1b9, which we have seen. It's a first step involved in platelet normal function, that is platelet adhesion. So 1b9 actually usually binds to the von Willebrand factor on the subendothelial collagen, and it is characterized by prolonged bleeding time, large platelets. There will be mild thrombocytopenia, and the platelet size will be usually giant platelets can be seen, and because of the platelet function is abnormal, there is prolonged bleeding time. And the inheritance is usually autosomal recessive. It can be seen in infancy, or even it can present in childhood. And sometimes it can even manifest later, which can be in the form of menorrhagia, postpartum bleed, or GI bleed even. And what is the classical pattern while doing platelet function test? It is a decreased or absent agglutination after exposure to ristocetin. Now, what is this ristocetin? So, ristocetin is actually a substance. It's actually an antibiotic. If it is added to normal blood, its property is it will help platelet glycoprotein 1b to bind to 1 Willebrand factor. In the means only in the normal state, this process
You are not audible. Sir, not audible. Not audible.
Am I audible?
Yes, sir.
Okay, okay, because there happened some issue with the net connection. So once you add
Okay.
a restore setting to a normal blood, it will produce agglutination. That means binding of 1B9 to 1 millibrand factor even without any other stimulus. But remember, this only produces agglutination, not aggregation, because to say aggregation, it involves 2B3A with fibrinogen. So without presence of fibrinogen in 2B3A, we won't call it as aggregation. So this is called agglutination. So when 1B9 is absent, even if we add ristocetin, there will not be any agglutination. So that is a classical test for identification of Bernard-Soulier syndrome, decreased or absent agglutination after exposure to ristocetin. Now, because the exactly same finding, absent or decreased agglutination to ristocetin can happen with von Willebrand disease also, because we know we are telling that 1B9 binds to 1 Willebrand factor. So if there is 1B9 defect or VWF defect, the pattern can be similar. Now, if you suppose we don't know what is a defect, whether it is 1B9 or 1 Willebrand factor. Now, if to the defective blood, if we are adding normal plasma, so we know that normal plasma contains 1 Willebrand factor. So if the defect is corrected, then it is called von Willebrand disease. But if the defect is not corrected, then it can be concluded as it is Bernard-Soulier syndrome because of the 1B9 deficiency. Then, defective agglutination is only after exposure to ristocetin, but aggregation patterns with other agonists such as ADP, collagen, epinephrine, all others are normal in Bernard-Soulier syndrome. Now, what about Glanzmann's thrombocythemia? Because we were talking about acquired Glanzmann's thrombocythemia, and I was mentioning it was antibodies produced against 2B3A. Now, in inherited Glanzmann's thrombocythemia, those 2B3A is completely deficient. So, there is prolonged bleeding time. Platelet count will be usually normal, but platelet aggregation is affected because we know that 2B3A is the most important glycoprotein involved in platelet aggregation. But for remember platelet aggregation, we always require fibrinogen to be there. And the bleeding pattern is similar to other platelet disorders. And usually platelet count and morphology on peripheral smear are normal. But what happens in the classical pattern in platelet aggregometry is there is absent agonist stimulated platelet. I mean, suppose when we will be seeing what is a platelet aggregometry in detail a bit in the later slides. In this disorder, Glanzmann's thrombocythemia, classically reveals absent agonist, any other agonist you add other than ristocetin, because ristocetin will produce agglutination and doesn't require to be 3 or 5 months. So you can leave alone ristocetin. If you add any other agonist, it will produce defective platelet aggregation. And what can be the treatment? When you can give platelet transfusion, then if the bleeding is very severe and which is not responding to platelet transfusion, we can even think of giving recombinant factor 7A. And rarely it has been reported that some of the patients can be salvaged with hematopoietic stem cell transplantation. So that is inherited Glanzmann's thrombocythemia. Then what about gray platelet syndrome? So in the platelet function sequences, The second step we were talking about was platelet activation, and the platelet activation means it is a release of granular contents to the cytoplasm as well as extracellular space. So granular content means there are two types of granules in platelet. One is alpha granule, other one is dense granule. Now suppose there is complete deficiency of alpha granule, then that situation is called gray platelet syndrome. And so the patients usually present with a lifelong history of mild to moderate mucocutaneous bleeding. And they also can have moderate thrombocytopenia. And usually platelet morphology will be giant platelet or large platelets. And usually they appear gray. Gray appearance is because of the lack of the granules. And what platelet aggregation study, usually they are normal because the contents from other granule, dense granule usually compensate for whatever defect is there in the alpha granule. Now another disorder, Wiskott-Aldrich syndrome, X-linked recessive disorder, and it is usually associated with immunodeficiency and dysfunctional platelets. Then the characteristic features or classical finding is significant thrombocytopenia and the presence of microthrombocytes, smaller than normal platelets. Then it is usually told that the patients have a storage pool-like disorder. And with the storage pool-like disorder, we will be coming to what is it in the coming slides. And usually aggregation is defective. Then another point is, with regard to treatment purpose, if there is significant bleeding, one of the treatment option is platelets. But patient being highly immunocompromised or immunodeficient, it is always preferable to give HLA matched platelets to avoid allo sensitization. Then another thing is, we know that in any immunosuppressed patients, it's always preferable to give irradiated blood products as well as CMV negative if available. That's not always a must, but blood irradiation is always preferable. Then storage pool disorders. Then what is storage pool disorders? So that we saw one is alpha granule complete deficiency, which is called gray platelet syndrome. And second thing is if the other type of granule, that is dense granule, that can also be deficient. And then other storage pool disorders are, means the storage pool disorders means defect in the sense that a deficiency of various granule contents. Those can be Chidiac-Higashi syndrome, Hermann syndrome, means those are rare phenomena. Then even TAR syndrome is considered as storage pool disorder. Thrombocytopenia, absent radiation. Then think of a situation where the platelet membrane glycoprotein is normal, granules are normal, granule content is normal, but the platelet is in a state where it is not able to release its granule. So that is, or secrete its granule. So this is a condition called platelet release or secretion disorder. It means there is defective granule release, but there is no actual deficiency of granules. Granule as well as granule contents are normal, but their platelet is not able to release the granule contents to cytoplasm or the extracellular space. And usually clinically manifest as mild to moderate bleeding, and the bleeding time can be prolonged. Then there is a, regarding the first and second wave of platelet aggregation, I'll be showing a picture, then we'll understand. But in platelet secretion disorder, there is classically absence of a second wave of platelet aggregation with ADP and epinephrine. So that we will see later. And also there is decreased aggregation with collagen. Usually the defect is in aggregation because we know that only after release of granules, aggregation means conformational change in platelet glycoprotein 2B 3A happens, and then aggregation process happens. So as such, aggregation is defective. Then immediate differential diagnosis can be, the similar pattern can be mimicked by aspirin or even conditions of systemic disorders like uremia as well as multiple myeloma. Then what are the other rare
Not audible, sir.
Am I audible?
Yes, sir.
Okay. Other platelet defects. Then we have seen that in on any platelet surface, membrane surface, for the released granules to act on another platelet and activate it, it requires multiple receptors for various agonists. So say ADP, collagen, epinephrine, all those things should have a receptor on platelets to attach to. So suppose there is a deficiency of ADP, it's called congenital deficiency of ADP receptor. So all those things can also produce platelet functional disorder. So when there is deficiency of ADP receptor, it can produce mild to moderate bleeding disorder. And usually it is suspected when ADP at very high concentration, platelet aggregation will be defective even if you add ADP. Then other rare phenomena are SCORD syndrome, autosomal recessive condition, and it can produce prolonged bleeding time, reduced incidence of thrombosis. Means the common floating pathway can get affected, and this is because we have seen that once an aggregation process is happening, the last step is coagulation formation, means clot formation. For the clot formation, there should be changes in the platelet membrane glycoprotein, so that more and more coagulation factors can come onto the surface to produce a clot. But in this syndrome, that membrane protein or phospholipid reorganization doesn't happen in response to platelet activation aggregation. So that clot formation is defective. So that is why we have written reduced thrombosis spot syndrome. So those were mainly the clinical aspects. Now let us see what is platelet function testing. Platelet function testing in the basic aspects of platelet function testing and how is it performed. Some of the mainly theoretical aspects from a clinical point of view. So before opting for a platelet function testing as such, before that we have to make sure that other basic tests like a complete blood count and peripheral smear examination is performed. Because a complete blood count, a platelet count, WBC differential count, all these can give us some clue whether there is another disorder which predisposes the platelet patient to a platelet function abnormality which is acquired, need not be always congenital. Now, say we are checking a peripheral blood smears, what are the specific conditions which can be identified in a peripheral smear which can induce platelet dysfunction? Say we have seen myeloproliferative neoplasm, which can be picked by a peripheral smear. Suppose it is CML or essential thrombocytosis. All those things can be picked up easily by a peripheral smear examination. Then another thing is in case of myelodysplasia, there are situations where patients with myelodysplastic syndrome are prone to development of platelet dysfunction. And then paraproteinemia we have already told. So plasma cell disorders, presence of abnormal plasma cells or increased rouleau indicative of paraprotein, all those things can be identified. Or you can have a clue from peripheral smear regarding these diagnoses. Now, another thing is when there is large platelets, we have seen some of the disorders, congenital disorders can have large platelets or giant platelets. But in even normal conditions in the sense that suppose the patient has got ITP, that is, there is an accelerated platelet destruction as well as accelerated platelet turnover. So in the peripheral smear, we can identify large platelet. Then congenital disorders associated with macrothrombocytopenia, that is Bernard-Soulier syndrome. And there are some other giant platelet syndromes where we can see large platelet. Then classical situation in which platelets are small with a platelet function abnormality is Viscotalger syndrome, which we have already seen. Then this gray platelet, and means platelet can be pale looking because of the absence of granules. and they are called hypogranulated. So that is a gray platelet syndrome because of the deficiency in alpha granules. So this is a normal peripheral smear, and we can see these are the platelets, and look at the size of the platelet in the normal situation. And this is a mature lymphocyte which with a nucleus which is almost the size of a normal RBC. So this is the relative size of a platelet when compared to a lymphocyte as well as RBC. Now this is the giant platelet, where the size of the platelet is almost equal to the size of a nucleus of a mature lymphocyte. So that is a definition of giant platelet. So multiple giant platelets we can one here, so multiple giant platelets. Now always when we see low platelet count, always we have to make sure that we are dealing with actually low platelet count. So there can be two different methods by which we can confirm the actual platelet count. One is manual platelet count, and usually it is told that it can be imprecise method, and some of the situations not always practical for every patient getting manual platelet count may not be practical. But nowadays we are blessed with the presence of all these automated cell counter methods, and which we all know it is rapid, precise, and reproducible. But there are situations, I mean, 2-3 different situations we have to think of. One is I have mentioned, there can be situations, there can be, because of the overestimation of platelet count. That means usually the counter, the basic principle is the cells are counted based on the size. So RBC has got a particular size, WBC has got a particular size, platelet has got a particular size. So the machine will count the cell as a platelet if it is having the size of a normal platelet. Suppose the size of the RBC, so that is as we see in thalassemia, where there can be extreme microcytosis, means very small RBCs. Sometimes by mistake, machine can count those RBCs as platelets, so that can lead to high platelet count. And another thing is thrombotic thrombocytopenia. Again, there will be significant hemolysis and fragmented RBCs. Very small RBC or RBC components or fractions can be there. That can also be counted by the machine as platelet, so that there may be overestimation of platelet count. Then exactly the opposite phenomenon. That means if the platelets are large or giant, just like what we saw in the picture previously, so those platelets will not be counted by the machine as platelet. Those will be either counted as WBC or RBC in that way. So in patients with large platelet, the machine may give us lesser than what is the actual value of platelet count. The conditions can be immune thrombocytopenia, where the platelet count can be underestimated. Another point is the phenomenon of pseudothrombocytopenia. Sometimes what happens is, I mean, this is rare, but definitely we have to always think of this phenomenon. EDTA induced satellitism, it's called satellitism. So it is usually rare, seen in less than 1% or less than 0.1% of the cases. But EDTA sample, if the platelet count means CBC taken in a CBC sample taken in EDTA bottle and then run in the machine, then there will be platelet clump formation, and those clumps will not be counted as platelets. So the machine will be giving very low platelet count, but actually when we see the peripheral smear, we can see platelet clumps sitting there, so that we can be sure that platelet count is normal. So this phenomenon is called pseudothrombocytopenia. So a few points about platelet aggregometry. So one is the classical platelet aggregometry. So the method is called turbidometric platelet aggregometry. It is developed as early as 1960s. And the basic principles are: first, whole blood is taken, then that has to be centrifuged at some particular force, low force usually. Then first step is you should get a platelet-rich plasma. That means plasma which has got platelet content. Then this platelet-rich plasma. So for the test, we need to have platelet-rich plasma. Then the next step is this platelet-rich plasma is stirred in a cuvette at 37 degrees Celsius. So the body temperature is very important. And there are two settings in this. One, there is a light source which emits light, and then there is a photocell on the other side which actually measures the light that passes through the cuvette. That means at the center it is a cuvette with the PRP. Then on one end it is a light source, and the other end it is a measuring photocell. So we know that platelet-rich plasma is said to be turbid. Turbid in the sense it is not clear because there are platelets hanging in the plasma. Now suppose we add an agonist. Agonist means some agent which is going to induce platelet aggregation. The agonist example ADP, then these platelets usually aggregate. Now when the platelets aggregate, they form clumps, and obviously their weight increases, and then the clumped platelets usually settle so that the plasma goes on getting cleared. So once the plasma is getting cleared, it will try to pass the light more and more. So once there is aggregation, there is a resultant increase in transmission of light. That means the turbidity of the PRP is reduced. Now this increase in light transmission is usually recorded as a function of time after addition of reagent. And as I mentioned, this overall phenomena reflect the formation of a relatively large platelet aggregate. I hope you understood what I told. So then the next thing is the turbidometry is being aggregometry is being continued. Then the usual agonists are collagen, ADP, epinephrine, ristocytin at a range of concentrations. Now, what is the importance of range of concentration? There are situations in which only classical strength of concentration will be able to induce aggregation. But there are situations where, because of the hypersensitivity of either the receptor or the glycoprotein, even small concentration or lesser concentration of the agonist can lead to platelet aggregation. Now, this agonist will lead to classical platelet response that we have seen. There is a shape in the change of the platelet, then primary and secondary aggregation that we'll see in the next slides. And then this response also, this time response also depends upon normal functioning of the platelet, and if there is any inhibitors of platelet function, and concentration, as I have already mentioned, concentration of the agonist. Then based on the pattern obtained, we can be able to derive it some clue, or sometimes we may be able to diagnose even classical platelet disorders by the aggregometry. But what is there? I mean, definitely it is not without limitations. It is labor intensive and it requires careful quality control and technical expertise for the performance and interpretation. And obviously, this is like highly specialized test, and it is limited to specialized laboratories only. And what happens is, suppose the platelet count is less, or the aggregate formation is less because of less platelet count, this turbidometry cannot be used. Either count less or count very high, then there is problem of interpretation with this test. So talking about the agonist in details, addition of platelet agonist to PRP leads to activation. Then this is we have already seen. Then regarding ristocytin, I have said at the beginning, like ristocytin will not produce platelet aggregation. It will produce only platelet agglutination. That point is very valid because we need to interpret some of the curves in the coming slides, and that is based on this phenomenon. Ristocytin able to induce only agglutination. Now, what are this primary wave and secondary wave? So that we will see here. Suppose there are we add an agonist called epinephrine or adrenaline, then it induces something called a biphasic response. So there are two waves of aggregation. That is why biphasic. The first wave, it indicates activation and then change in the 2B3A glycoprotein, and then first step of cross-linking of fibrinogen, means first phase of aggregation. Then once that aggregation phenomena happens, further platelets are activated, or the platelet is further activated, leading to more and more release of granules and then an enhanced aggregation process. So this is the second wave. So if there is an agent which induces these two waves in a biphasic manner, that agent is called a weak agonist. Means it can work only in that fashion in two phases. But if there is an agent which is called a strong agonist, it will directly induce the full burst of aggregation. So there is no primary wave. There is no primary wave of aggregation. It is only a single phase response. Once you add arachidonic acid, collagen, or thrombin, it will produce the full burst of aggregation. There is no primary and secondary waves differently. So there is no biphasic response if you add a strong agonist. So this is what I meant. Suppose this is here we add agonist. Then first one, this is a first step, platelet activation and release of granules and fibrinogen linking. So this is the first step, and that's called primary wave. Then once a fibrinogen linking happens, more and more platelets gets activated, and there is a sudden burst in continuous aggregation of platelets, so aggregation of large number of platelets, which leads to secondary wave. So this primary and secondary waves happen only with the weak agonist. Suppose there is a strong agonist, this secondary wave and primary wave are all merged. So there is no dip here, because the strong agonist can induce aggregation in a very fast manner, so that there is no primary and secondary waves. Now, how do we measure aggregation? So this is a baseline where there is 0% aggregation, which is full of platelets in the plasma. Now this is the 100% aggregation. That means platelet fluor plasma. There is no platelet here, so all the platelets have settled. So the plasma is very clear. So that's equivalent to platelet fluor plasma. So this is 100%. This is 0%. And suppose we add an agonist that can produce aggregation to various extent. So suppose this is measured as 100 and this is measured as 80 or 85, then it is called as 85% aggregation. Now, let us see some of the common patterns in platelet aggregometry. So what we can see is this is ADP, this is adrenaline, this is collagen, and last one is ristocyte. So what we see in blue is the control, which is normal, and what we see in red is called test sample. Now, when we add ADP, when we add adrenaline, when we add collagen, all the three produced aggregation just equivalent to the control. But when we see ristocytin, what we can see is that the control is good, like it produced what is being expected for an aggregation pattern. But for a test, the ristocytin, it's not come down. I mean, there is no platelet clump formation at all, because for ristocytin, as I mentioned, we don't talk that it is aggregation, it's always agglutination. So ristocytin failed to produce agglutination. So what does this mean? If ristocytin is failing to produce, there can be only two reasons. One is glycoprotein 1b9 deficiency or 1 Willebrand factor deficiency. So it is either Bernard-Soulier syndrome or 1 Willebrand factor, means 1 Willebrand disease. Now let us see this pattern. So blue is control. So the blue has worked very well, full aggregation. Now ADP added, no aggregation. Adrenaline added, no aggregation almost. Collagen, no aggregation. While for ristocytin, you see the classical agglutination. It means it has come down, it has agglutinated. Why the curve is not coming down? Because we have seen this is platelet aggregation, but this is only agglutination. Now, so what does this mean? So patient's plasma is responding only to ristocytin, but for all other agonists, there is no aggregation. So aggregation always requires glycoprotein 2b3a or fibrinogen. So when there is 2b3a deficient, it is called Glassman thrombocythemia, or if it is fibrinogen deficient, it is called afibrinogenemia. So this is the two conditions where this pattern can happen. Now this is the storage pool or secretion defect. Storage pool means there is absence of granules, and secretion defect means there are granules but which is not able to secrete. So this is what we can see is only the primary wave of aggregation happens, because aggregation started but it has gone back to 0 value. Again, aggregation started, it remains Plato. Then aggregation started, it remains Plato. But with restore setting, agglutination is happening. Means with the restore setting, the event is normal. But with ADP, adrenaline collagen, only primary wave. There is no secondary wave. So we know that for the secondary wave to happen, there should be release of more and more granules. So that is not happening. So that is what is a speciality or peculiarity of storage pool or secretion defect. Then, so because we will skip this, I think PFA 100. We have only 6 minutes. Just a word about PFA 100. It is actually another type of platelet function testing. Citrate and whole blood is aspirated a high whatever it is. So it's based on a closure time. So there will be a flow system with a aperture at one end, and then platelets are being run through that flow system, and the aperture means the around the surface of flow system there will be agonist added, and based on the platelet aggregation or speed of platelet aggregation, there will be closure of the aperture, and this time is called closure time. And just like what we see in aggregation studies, this closure time is an indirect measure of platelets getting aggregated by the addition of any of these agonists, collagen, epinephrine, etc. So those are the various interpretation of this PFA 100 that you people can refer. Now a few points about reticulated platelets. So actually this RNA inside plate, usually platelets are anuclear, but early released platelets, nucleic acid specific dyes can be utilized to measure young platelets that can contain residual RNA. So this is actually equivalent to red cell reticulocytes and have thus been termed reticulated platelets. It's a non-invasive method of assessing platelet turnover or thrombopoiesis, and it's also a predictor of marrow recovery after bone marrow transplantation. Also can be utilized to monitor the response to therapy with growth factors such as thrombopoietin. But fortunately, now the automated machine can give this value also. Immature reticulo means just like reticon, there can be the machine itself can give us immature platelet fraction, otherwise called nucleated platelets. Now these are some exercises I have put, but it may be, I think, difficult in this webinar to have communication from you. So with that, I think we'll stop. Thank you very much.
Thank you, sir, for that elaborate talk on platelet function, both clinical and laboratory perspective. Now the audience, you can ask any queries. We have around 77 attendees as of now, and the profile of attendees or participants are from junior residents to professor grade are attending. So if anyone would like to ask any query, I am unmuting you. You can directly go ahead and ask. If anybody has any question, you can raise your hand option also, you can use. Any queries? Muhammad Anas Sheikh, you can unmute yourself and ask. Muhammad Anas. I don't see any queries.
Okay.
Dr. Saurabh, I think Dr. Saurabh Lahare. Yeah, you can ask.
Yeah, hello sir.
Saurabh.
Am I audible? Hello.
Yes, yes.
Yeah, go ahead.
Proceed.
My question is, why there's a platelet dysfunction in uremia? What is the exact mechanism?
I didn't get your word.
Why
Mechanism.
there is platelet dysfunction in uremia? What is the exact mechanism?
Yeah, I have shown some slides. I can in the uremia I have shown you. So these are the mechanisms. So one important mechanism which I wanted to tell is one is patients will be usually on major if it is like CKD requiring dialysis. One is heparin, which is actually leading to coagulopathy. Another point is means many of the patients will be severely anemic because there will be anemia of chronic disease. Then I was explaining this, like when there is severe anemia, the peripheral distribution of the platelets in the flowing bloodstream will be affected, so that less adhesion of the platelet to subendothelial collagen or subendothelial matrix. Then other reasons are means only with regard to platelet function, there can be metabolic defects in platelets, intrinsic phenomena, and a platelet endothelial interaction. The explanation I have already told. Anemia, severe anemia.
Okay, sir. Ajay, what should be the HB level below which platelet dysfunction will get affected? What is the HB
And
level?
the exact level means I am not sure whether there is such a data access like below this type of hemoglobin platelet function gets affected. Depends also multiple. It is can be as it can be multi like factorial. There may not be a particular cutoff of even if the hemoglobin is like 9. If there are other issues like coexisting coagulopathies or metabolic defects, it can affect platelet function, right? So there may not be a cutoff, clear-cut cutoff. Means I am not aware of any such data which shows that below a particular cutoff of hemoglobin, platelet function gets affected.
Okay, sir. Thank you.
Mohammed Anas, you can go ahead and ask. Muhammad Anas Sheikh. He has asked in the chat box. The question is EDTA induced pseudothrombocytopenia on peripheral blood smear. Are platelet clumps counted or as equivalent to 5,000 to 10,000 platelet, or is simply given as adequate platelet?
1 second. Let me see chat box. What is written?
EDTA induced pseudothrombocytopenia on peripheral smear, and we
Yes.
get it a count as 5,000 to 1,000 as platelet count. Do
Yes.
we or the question is, or is simply given as adequate platelet? That's what he has written.
By the peripheral. Okay, okay. So what is to be written is like either means usually in a hyper field, if we see like 10 or 15 platelets, then it is usually called adequate. And if by seeing clumps, it may be very difficult to count the exact number of platelet. So if there are large clumps or large number of clumps are seen, it can be very well written as adequate. Even the exact count, we may not be able to tell.
Okay, sir. If does anyone have any queries? If not, we'll go to the next session. Thank you, sir. Thank you, sir, for your elaborate talk on platelet.
Thank you very much. Bye. Good luck.
Thank you. Next, I call upon Dr. Sriraj. He's MD DM Clinical Hematology. He has done it from AIMS Delhi. He's at present assistant professor and consultant in hematology from Amala Institute of Medical Sciences. So now you can share your screen, sir. Dr. Sriraj. You have to unmute yourself also.
Please muted. Yeah. Fine. You're seeing my screen, right?
Yes, sir.
Are you seeing my screen? Yeah. Thank
Yes,
you.
sir.
Uh,
You have to make it full screen, sir.
yeah. Good afternoon. Myself, Dr. Sriraj. I did my DM in AIMS in 2016 and then currently working in Amala. I would like to thank Dr. Sushila, Madam, and Dr. Rafi for giving me the opportunity. Now, the topic which I discuss will be the thrombophilia testing and its clinical importance. When I started reading for this topic, it was very vague. It had a lot of confusing articles, and there were no specific guidelines to do as like we have guidelines for coagulation. We have guidelines for DVT treatment, but we don't have a definite guidelines for hypercoagulable state, testing for hypercoagulable state. So I read some of the articles and made a presentation which we will discuss the next 30 to 40 minutes. My talk will be basically oriented around clinical situations. Laboratory evaluation will be the discussion will be very minimal because many of the lab investigations are very tough even for me to understand. It is very tough to understand even for me. Now I'll be discussing, there'll be an introduction, and I'll be discussing about the natural anticoagulants and its testing, clinical scenarios, and what algorithm we should do if we decided to go for testing, and then there'll be a summary. Now, this is the man, Rudolf Virchow. He is the pioneer of thrombophilia evaluation. He is the father of modern pathology. He in 1856 he pointed out that pulmonary embolism is due to a blood clot from somewhere else. It may be a blood clot from distal legs. He identified this deep venous thrombosis as a cause of pulmonary embolism by autopsy study. Now, after his death, around 100 years after his death, around 1950s, we came to know about the triad, Virchow's triad, where the blood stasis, hypercoagulability, and vessel wall injury each has a definite role in thrombosis, and each factor interplays with other factors to result in a intravascular thrombosis. Now, the coagulation cascade, you'll be aware, there is an initiation phase where the exposed tissue factor activates factor 7A, which leads to activation of factor 10 and thrombin generation. And once the thrombin is generated, the thrombin activates amplification phase, where there'll be predominant factor 8, factor 10A complex mediated thrombin generation and fibrin generation. So if you don't control this coagulation amplification, you will get extensive thrombosis even for a minor injury. So there are systems in which the coagulation cascade is self-controlled, and these systems are mainly anticoagulants. So these systems are mainly controlled by anticoagulants in our body. The main three main anticoagulants in our body are antithrombin 3, protein C, and protein S. We'll be talking about these three enzymes in the coming slides. Now, if you ask for risk factor for thrombosis, there is an interplay between the genetic risk factors, environmental risk factors, behavioral risk factors, and there is a combination of these risk factors. If you look for the causes of an idiopathic venous thromboembolism, up to 50% of these patients may have a genetic predisposition. We may not test everybody, so but if you look into the genetic predisposition, at least 50% of the people with idiopathic DVT will have a genetic risk factor. Now, the environment risk factors are like most common are indwelling catheters, associated cancer, elderly age, and then acquired causes like antiphospholipid antibody syndrome, paroxysmal nocturnal hemoglobinuria, myeloproliferative neoplasm. These are the environmental risk factor for thrombosis. Then our behavioral issues like immobilization, pregnancy, obesity, OC pills, smoking and travel. These are the behavioral risk factors. All these risk factors play in with one another. Now, this cartoon shows we have an intrinsic when we develop an venous thrombosis, we have an intrinsic thrombosis risk from a genetic risk factor like the anticoagulant deficiency or factor V latent mutation or prothrombin gene mutation, and we have an acute risk factor like our age, previous venous thromboembolism, cancer, obesity, hormone treatment. So we have an intrinsic thrombosis risk on which we have a triggering risk factor like these patients who have an intrinsic thrombosis risk but they never develop a DVT, when they get pregnant or when they undergo a surgery or immobility, they will develop a thrombotic episodes. Now, if you see the evolution of hypercoagulable testing, the first test which was made available for clinical use was antithrombin 3 deficiency testing by 1964. Now, antithrombin 3 is an enzyme which inhibits the majority of clotting factors except factor 5 and factor 8. It inhibits factor 2 prothrombin, it inhibits factor 9, 11. So it's a very potent enzymatic inhibition method. Now, antithrombin 3 deficiency is actually very, very rare. Even in well-studied Caucasian population, the incidence is very rare. Homozygous deficiency is not reported. It will be the fetal the homozygous antithrombin 3 deficiency is not viable to life. It will be the fetus will die in the placenta. Heterozygous deficiency is autosomal dominant. There are qualitative and quantitative defect. The gene which codes for antithrombin 3 is in chromosome 1. Now they have functional sites, reactive sites, which participates in an interaction with proteinases, the protein factors, but they have an also binding site for heparin and other glycosaminoglycans. Once heparin is bound with the antithrombin, there is a conformational change, and it accelerates the inhibition of proteinases. So antithrombin 3 has a enzymatic activity site, and there is a heparin binding site. Heparin binding site, once heparin is bound, the activity of antithrombin increases. Now, antithrombin 3 deficiency, there are two types of antithrombin deficiency. One is type 1, where the activity and the concentration of antithrombin is reduced. In type 2 antithrombin deficiency, the activity is only the functional enzymatic function is reduced, but the quantity of enzyme will be normal. There are some subgroups for the type 2 antithrombin deficiency depending upon where the mutation affects. Now, if you look for the mutation, there are a lot of mutation. There are a lot of genetic variants of antithrombin deficiency, both for type 1 and type 2. Now, the adult reference range is around 82. The normal activity should be around 80% to 120%. When you suspect antithrombin deficiency, the first thing you have to do rule out is acquired causes. Antithrombin is produced in liver, so we have to rule out liver disease. Antithrombin is secreted through urine, so you have to rule out protein losing conditions like nephrotic syndrome. And if you use hormonal therapy, estrogen hormone therapy, the antithrombin level will be low. L-asparaginase treatment will result in antithrombin level will be low. So acquired causes of antithrombin deficiency we should keep in mind before labeling the patient as antithrombin deficiency. The most common method of functional assay of antithrombin deficiency is chromogenic activity assay. High concentration of hemoglobin, bilirubin, and triglycerides increases it may affect the antithrombin measurement. Now, this is the algorithm where proposed. Now, you perform a chromogenic assay of antithrombin functional assay. If the activity is less than 80%, then you have to repeat the functional assay, and we have to perform an antigenic assay also, ELISA-based antigenic assay. So, functional assay initially, first step is functional assay, and if the values are low than the cutoff, then you have to perform a repeat functional assay, and then an antigenic assay. And by which you can differentiate the type 1 and type 2 deficiency. Now, genetic testing is usually not preferred for diagnosis because of there are a lot of genetic variation, a lot of mutations are there for the antithrombin deficiency. So functional assay is always better for diagnosis. Now, next test which were available for hypercoagulable testings were protein C and protein S deficiency, which came to clinical use by 1981 and 1984. Now, if you see protein C and protein S, they are proteinases which inhibit factor 5 and activated factor 5 and activated factor 8. Now, when thrombin is generated, the thrombomodulin combination activates the protein C, and protein S is a cofactor for the protein C mediated inhibition of factor 5A and factor 8A. Now, these are also extremely rare. It's an autosomal dominant inheritance. There are many mutations. If you see in general, proteins, there is type 1 acid antithrombin deficiency. Type 1 deficiency is a quantitative defect. Type 2 deficiency is a qualitative defect. Now, acute causes like liver disease because protein C and S is produced in liver. Vitamin K deficiency because vitamin K, these are the vitamin K dependent factors. And if there is a factor 5 laden deficiency also, factor 5 laden mutation also, then the estimation of protein C and protein S will be spuriously low. So rule out these acute causes and factor 5 laden defect. Now, homozygous protein C or protein S mutations present in utero, the baby will be born with extreme hyper DAC, resulting in skin necrosis. It's called purpura fulminans. Identification of this phenomenon is very life-saving. You have to treat the patient with plasma. Now, the incidence of protein C's deficiencies around 0.14 to 0.5% in general population. These are Western data. There are a lot of mutations. It causes around 11%, 1 to 11% causes of venous thrombosis in general. The heterozygous mutation, the normal protein C level varies between 35 to 65%. So if the level is less than 65%, it's abnormal. And the first thrombotic events occurs between the age 10 to 50 years. Now, every patient with protein C deficiency develop venous thromboembolism? No, only 30% of this protein C deficiency develop any form of thromboembolism in their life. Now, assay. Now, there is a chromogenic assay is there, functional assay. There is a clot-based functional assay is also there. These are the preferred based assays, and there is an antigen assay based on ELISA method and genetic testing. The preferred method, as in antithrombin deficiency, will be functional assay. Chromogenic based assay will be preferred. Now, similar to protein C, the protein S deficiency is also autosomal dominant. Homozygous patients present with purpura fulminans in the neonatal period. The levels are almost the first thrombotic event occurs between 10 to 50 years, and the risk increases by age. Around 50% risk of developing a venous thromboembolism at the age of 45. Now, the problem with protein S is actually a cofactor. It is bound. There are two forms of protein S in the serum, in the circulation. One is a bound form, bound to complement factor B protein, and there is a free protein S. The free protein S is actually enzymatically active. Now, there are three forms of deficiency. Type 1 is the quantity is less. The quantity of free and total protein S is less, resulting in a decreased functional assay and quantitative assay. Type 2 is normal antigenic, normal quantity, but the function is decreased. Type 3 is only the free protein S is low. Now, it is very difficult to assay the functional assay, difficult to detect the functional assay of this protein S deficiency. So the current recommendation is to do an antigenic assay of protein. If you are suspecting protein S deficiency, do an antigenic assay by ELISA-based method. That will be much productive than doing a functional assay. Functional assay results in a lot of false positive values. Now, this algorithm, protein C, if the protein C clot-based assay or chromogenic assay, if the function, if the level is less than 70%, then do an protein C antigen, and we can classify it into type 1 and type 2. Borderline, you have to repeat an assay. If the values are more than 75%, no need. Protein S, the ideal method is protein S antigen assay and not the functional assay. Now, the next test which was found out was in 1983, antiphospholipid antibody syndrome. Now, it's an acquired cause of venous thromboembolism. Unlike the previous anticoagulants deficiency, it's an acquired cause. The pathophysiology is you develop antibody against phospholipids. These phospholipids are there in our cell membrane. All the cells cell membrane has phospholipid. So whenever there is a antigen antibody binding, whenever the phospholipid and antiphospholipid antibody binds, it results in an immune reaction, immune activation in the downstream. It results in a complement activation. It results in a neutrophilic activation. It results in platelet activation. That is the result. That is the reason for thrombogenic potential. When you activate the plate, when there is an antibody antigen interaction in the platelet surface, it activates the platelet aggregation and result in coagulation activation. Now, if there is a the antiphospholipid antibody inhibits the protein C, protein S, thrombomodulin, antithrombin 3, and fibrinolysis. These are the phospholipid dependent proteins, and it increases the tissue factor expression in endothelial cells. It increases the pro-inflammatory cytokines from endothelium. It decreases the trophoblastic cell growth and increases the apoptosis in plasmal tissue. So the ultimate end result will be thrombosis and platelet loss. Now, antiphospholipid antibody syndrome, both arterial and venous thrombosis can happen. Now, I am not going for the going into the testing methods and the diagnostic diagnostic criteria. It's already you would have a class and topic on that in the next few days, I think. Now, the next anticoagulant, next hypercoagulable test which was available is in 1988 was methyl tetrahydrofolate reductase mutation. Now, methyl tetrahydrofolate reductase is an enzyme which is essentially in one carbon metabolism. The methyl tetrahydrofolate reductase enzyme is used to revert homocysteine to methionine. If there is a deficiency, the homocysteine increases. Now, the increase in homocysteine is the result is the primary pathogenesis resulting in increased thrombosis. Increased homocysteine inhibits the angiogenesis from endothelium. It increases the tissue factor expression. So the end result will be increasing the activating the coagulation cascade and inhibiting angiogenesis, resulting in thrombosis. Now, the current concept is you test homocysteine first, and if the homocysteine is elevated, then only you go for methyl tetrahydrofolate reductase mutation study, because many methyl tetrahydrofolate reductase mutation, many variants have normal homocysteine level and they are not thrombogenic. So current understanding is, in the absence of elevated homocysteine, the methyl tetrahydrofolate reductase is no longer considered a risk for venous thromboembolism. So current algorithms doesn't include methyl tetrahydrofolate reductase testing in hypercoagulable workup. Now, if you see a high plasma homocysteine level, you do a fasting plasma sample. You repeat the test in a fasting plasma sample, and then you rule out renal insufficiency, vitamin B12 folate deficiency. Then we come into diagnosis of primary homocysteinemia. Then go for genetic testing. Now, the next mutation, which was next hypercoagulable test, which was identified was factor V Leiden mutation, which was identified in 1994. Now, factor V Leiden is actually is a gain of function mutation. Once you have this point mutation, the factor V, activated factor V, will be resistant to protein C mediated inhibition. Now, this is the most common inherited thrombophilia. Around 5% of Caucasian population have this mutation with them, and the inheritance is autosomal dominant. We can have both heterozygous and homozygous mutations in the population. Unlike the protein C, protein S, and antithrombin, the homozygous, for them, for the natural anticoagulants, the homozygous mutation is very there is high mortality with this homozygous mutation in utero or in the neonatal period, but factor V laden homozygous mutation can happen in adult life also. Now the screening of this this factor V laden mutation is through a functional assay called activated protein C resistance assay. And once you have an activated protein C resistance assay abnormality, then you can confirm the diagnosis by genetic testing. Now, if you the basic principle of activated protein C resistance assay is you do an APT, this is an APTT based assay. You do an APTT in the patient's plasma, and then you do the APTT after activating activated protein C. So the concept is if you are adding activated protein C, that will inhibit the clotting factors. So you expect a high APTT value. Now, if you have factor V laden mutation, that will resist the activated protein C. So the APTT value will not be that much higher. So depending upon the ratio of clot time with APC calcium added APTT with normal APTT, we can detect the presence of activated protein C resistance. If the ratio is more than 2.3, there is no evidence of activated protein C resistance. If the ratio is less than 2.3, then there is a chance of factor V laden mutation, and then we'll do the factor V laden mutation study. Now, there are many rare causes of activated protein C resistance other than factor V laden mutation, but the most common cause is factor V laden mutation. So that is about factor V laden mutation. Now the next gene which was identified was prothrombin mutation in 1996. This is from the University of Leiden. This factor V laden mutation and the prothrombin gene mutation was identified in University of Leiden in Netherlands. They are the pioneers in hypercoagulable workup. Now this point mutation G20210A it's also seen in 1 to 3% of Caucasian population. The mutation happens in 3' untranslated region of prothrombin mRNA. This results in increased prothrombin generation from the mRNA, and the increased prothrombin results in increased venous thrombosis. Heterozygous and homozygous mutations effects can happen. It also inherits in autosomal dominant fashion. Homozygous mutation is very rare, and there is only genetic testing available for this entity. Now, the other uncommon causes or newly detected causes for thrombosis are one is elevated factor VIII level. Persistent elevated factor level more than 150% is an independent risk factor for thrombosis. Dysfibrogenemia is also a risk factor for thrombosis. This is an entity where the patient can have bleeding and thrombosis. So identifying dysfibrogenemia is also very important. Now, coming to the treatment aspect. Now, if you see you have a venous thromboembolism, the initial acute treatment doesn't change. It doesn't change even if you have thrombophilia, underlying thrombophilia, or even you have no underlying thrombophilia. The initial 3 months change will be same. Now, after 3 months, this is a current concept. After 3 months, then you have to decide whether you have to stop or you have to extend the anticoagulation. So that is basically a secondary prophylaxis to prevent further recurrence. Now, this area, this time period, we may need the hypercoagulable workup results may change our decision. So after 3 months of initial treatment, then we may need hypercoagulable testing results to aid our treatment duration. Now, the current concept is if you have a life-threatening venous thromboembolism, life-threatening idiopathic venous thromboembolism without any risk factors, without any common risk factors, then you are supposed to continue lifelong anticoagulation. Now, so is there a role of testing in that? If you are already decided to continue lifelong anticoagulation, why you need an anticoagulation testing? That's what we are coming to in the others in the coming slides. Now, why you should test for hypercoagulable state? Now, it's a public. The DVT is a public health. The venous thromboembolism is a public health burden. You expect 1 to 2 venous thromboembolism per 1,000 persons per year. In the US, around 50,000 people have life-threatening pulmonary embolism per year. Now, there is a risk of recurrent venous thromboembolism. Even if you test or even if you treat or you stop treatment, 30 to 40% of the people will have recurrence of venous thromboembolism. We are not at all successful in preventing venous thromboembolism or its recurrence. So that's why the testing, the thrombophilia workup starts interesting. Now, if you see the general incidence, these are all Western data. There is no. I will come to the Indian data in the later part of the topic. The Indian studies are very few. Now, if you see, the most common mutation, thrombophilic mutation is factor V Leiden in general population, around 3 to 7%, and then prothrombin mutation. If you see the serious ones, the high risk ones like antithrombin 3 mutation, protein C mutation, and protein S mutation, they are actually very rare, even in Western data. Okay, now if you come to the incidence in patients with one episode of venous thromboembolism, then the ratio increases. Actually, up to 20% of the venous thromboembolism patients may have factor V Leiden mutation. If you come to thrombophilia family, the 50% of patients will have factor V Leiden mutation. So, what this data indicates now, if you see, if you have a strong family history, the chance of having a primary thrombophilia defect is high. You don't even need a testing. You can say that up to 50% of the patients may have, the thrombophilia family may have factor V Leiden mutation. So that is a point. So there is a strong family history in the first degree relative is actually a very high. It's an indicator for underlying thrombophilia defect. Now, if you see, even if you have this factor V Leiden mutation or prothrombin mutation, you may not develop DVT at all. Most of the patients, around 50% of these patients with inherited thrombophilia, they develop DVT only when they are exposed to a risk factor like OC pills, consumption of OC pills, or pregnancy, or trauma or surgery. So majority of them have DVT only when there is risk exposure. Now, the risk of venous thromboembolism, the lifetime risk of venous thromboembolism is actually high if you have a protein C, protein S, or antithrombin deficiency. It reaches protein C deficiency, you have a relative risk of lifetime venous thromboembolism around ranges from 6.5% to 31%. Antithrombin deficiency, if you have antithrombin 3 deficiency, the lifetime risk of venous thromboembolism reaches up to 40%. But it is actually less in factor V Leiden or prothrombin mutation or hyperhomocystinemia. Now, if you have combination of thrombophilic mutations like factor V Leiden and prothrombin, the ratio increases. If you have a combination of thrombophilic mutation and then an acquired factor, then the risk actually increases much higher. So the implication of this slide is there are high risk thrombophilic states like protein C, protein S, and antithrombin deficiency, where the risk of deep venous thrombosis more than 1/3 of the affected persons. The other risk factors of thrombophilia are not that strong enough indicator for developing a DVT. Now, why we should test? In the coming slides, I will discuss about the potential benefits of testing. If you find if you have a spontaneous DVT patient, a spontaneous venous thromboembolism patient, do you need a testing in that point? Will the duration of anticoagulation changes if we find a positive results, or will in another way, will the positive results increase the recurrence rate? Now, this is actually a meta-analysis of different retrospective studies which published in 2009. They found that if you have a strong risk factor, the strong risk factor means antithrombin deficiency, protein C deficiency, protein 5 deficiency, protein S deficiency. If you have a strong risk factor, the lifetime risk of developing a DVT ranges from 40 to 55%. If you have weak risk factor, like factor V laden prothrombin gene mutation or high factor rate, the risk of recurrence ranges from 11 to 25%. At 5 years, 11%. At 10 years, 25%. If you have no risk factor in general population, if you develop a DVT, the chance of recurrence at 5 years is 22%, and at 10 years is 30%. So strong risk factors have a high incidence of recurrence. So detecting a high risk factor thrombophilic mutation may be helpful in deciding the duration of anticoagulation. All these patients had an initial treatment, and they completed the initial 3 to 6 months treatment, and then they followed up for 5 years to 10 years. Then and assessed the recurrence rate were assessed. Now, the interesting point in this article is, if any of these patients who have the thrombophilic conditions, when they continued anticoagulation, there were no recurrence. Now, the next question is, do these patients, the thrombophilic patients, have high, do they need high intensity anticoagulation? In other words, do they have recurrence even when we are treating them in the initial phase? This question is answered in 2008 Blood Journal by Caron et al., where they continued the patients. There are two sets of, this is a prospective study. One arm, they continued normal warfarin anticoagulation to maintaining between 2 to 3. In another set, they continued low dose warfarin. The aim of INR is to keep between 1.5 to 1.9. They found that even if you have thrombophilic mutations, there is no increased incidence of recurrence or treatment failure while patient is on anticoagulation. So this is the only guidelines which we have regarding the thrombophilic testing. The 2010 BJH guidelines, they gave some guidelines for to use when we have a spontaneous idiopathic DVT. They discourage indiscriminate testing of hereditary thrombophilia in unselected patients with first episode of venous thrombosis. And decision regarding duration of anticoagulation should be based on whether the first venous thromboembolism is provoked or unprovoked, and other risk factors, and the risk of bleeding. If you have a high risk bleeding patient, the continuing anticoagulation is not worthwhile, and the decision about duration of anticoagulation should not be based on hereditary thrombophilia. Now they again confused us with the third recommendation, where they said testing for hereditary thrombophilia in selected patients, such as those with strong family history of unprovoked recurrent thrombosis, may influence decision regarding duration of anticoagulation. So comparing the second one and third one, they are not clear. So the third one, they tried to say that if you have high risk thrombophilic conditions, you may continue anticoagulation if the bleeding risk is low. But at present, the last line they mentioned was, it is not possible to give a validated recommendation at present, so we need further studies. Now, that is one thing. So we covered the need of testing for the patient in the first unprovoked DVT venous thromboembolism setting. Now, should we now we found that we have a thrombophilic condition in a patient. Should we find asymptomatic relatives of venous thromboembolism patients who have this gene defect? Now, if you find this group of patients, the advantage is we can counsel them for modifying the risk factors. Like, we can ask them to avoid OC pills, we can ask them to avoid smoking, we can ask them to control the weight, and we can prophylactically anticoagulate these patients on when they undergo high risk situations, like when they undergo pregnancy, when they undergo surgery, when they undergo travel, we can prophylactically anticoagulate them. This is the aim of finding asymptomatic relatives with venous thromboembolism. Now, the question is, does the family history of venous thromboembolism results in an increased risk of venous thromboembolism recurrence? Now, you have a patient with venous thromboembolism. That patient had a family history. The first degree relative had also venous thromboembolism, DVT. Now, does this warrant that you need to continue anticoagulation lifelong? Now, this is a study from 2006. It's a retrospective study. They found that even after years after stopping anticoagulation, there is no difference between the recurrence rate in even patients with family history and patients without family history. But the drawback of this study is they excluded the high-risk anticoagulants deficiency like antithrombin 3C and protein C and protein S. So what they tried to say in the article was the family history doesn't predict recurrence, but why they excluded the antithrombin 3 deficiency, protein C and protein S, they didn't mention exactly the mention. They mentioned that the incidence of these three defects were very rare in their cohort. Now, in 2003, there is a meta-analysis of retrospective data which documented the incidence of venous thromboembolism in an asymptomatic family member with these mutations. The incidence of venous thromboembolism in factor V laden mutated family member is 0.5 to 0.6%. For protein C, the incidence is up to 2.5%. For protein S, it's up to 2.2%, and for antithrombin deficiency, it is up to 4% per year. This per year means every year it is adding up. So for an antithrombin deficiency, by the age of 50 years, you will have a 50% chance of more than 50% chance of developing venous thromboembolism. That study also pointed out that the venous thromboembolism occurred most commonly. The venous thromboembolism occurred during risk exposure, like surgery and immobilization. The incidence rates were decreased by prophylaxis. Now, this is another study, IPCOT study. This is a prospective study where they prospectively evaluated the family member with thrombophilia for around 7 years, and so they tried to find out the incidence of venous thromboembolism in this family. They also found out that this is a prospective study, so more weightage should be given to this study. Even if you have protein C deficiency or protein S deficiency, the risk of the incidence of DVT is only less than 1%. Even if you have combined defect, the risk of DVT is only 1.6%. So by this, they concluded that there is no indication for lifelong prophylaxis in a family member, even if they have the high risk mutation. Now they also pointed out that you may use prophylactic anticoagulants when these patients undergo risk period like surgery or pregnancy. So the BCHH guidelines mention not to find the asymptomatic relative with low risk of thrombophilia, like your factor V laden mutation or prothrombin gene mutation. There is no indication to test the family members. But if your index patient have antithrombin deficiency, protein C deficiency, or protein S deficiency, you may consider testing the asymptomatic family member in thrombosis-prone families. If testing is planned to perform, then we have to explain to the patient's family members about the risk of the risk benefit of testing this testing and the outcome. Now, another potential benefit of testing the index case is choice of anticoagulation. If you have antithrombin deficiency, your heparin is not going to work in the treatment, because heparin needs antithrombin in the treatment. Now coming to so we completed the index case testing, and we completed the asymptomatic family member testing. So asymptomatic family member testing, if the index case have high risk thrombophilic mutations, then it is you may test the family members if there is a family history of thromboembolism. Index case testing is actually still controversial, but we may identify the high risk anticoagulation and high risk thrombophilic mutations that will help in testing the family members. Now the next group of patients are pregnancy. Now if you have a pregnancy thrombophilic condition, the pregnancy outcomes are not good. They may have IUGR, they may have preeclampsia, they may have abruption, they may have placental abruption and fetal death. So this is a retrospective study which pointed out that If you have genetic thrombophilic defects like factor V Leiden homozygous mutation or heterozygous mutation or antithrombin mutation, all severe deficiency, protein C severe deficiency, you have very poor fetal outcome when you compare to the control pregnant ladies without these risk factors. So, so the guideline says if you have a pregnant lady with previous history of thromboembolism, previous history of DVT, then the subsequent pregnancy, you are automatically the patient should be on anticoagulation. So that group of patients, that we don't need testing. But if you have a previous event due to minor provoking factor like travel, then that pregnant lady should be tested for thrombophilia, and they should be subjected to prophylaxis if there is a thrombophilic condition. Now, asymptomatic woman with a family history of venous thrombosis in a first degree relative when it was unprovoked, then that asymptomatic woman should be tested for thrombophilic mutations and thrombophilic defects, and they should be on prophylaxis. Now, the pregnancy laws and testing. There are many studies which points that we have when you have a thrombophilic condition, you have high risk of miscarriages, intrauterine death, preeclampsia, and risk of abruption. Now, this is a 2016 study which found out that if you have prothrombin gene mutation, heterozygous prothrombin gene mutation, or if you have the methyl tetrahydrofolate reductase homozygous mutation, you have very poor outcome, your very poor fetal outcome. Other mutations are not statistically significant, so we need further data to say whether you need prophylaxis considering to improve the fetal outcome. Now, many obstetricians automatically starts the patient on anticoagulation, either aspirin or Clexane, when you have repeated pregnancy loss. But that is actually it's a clinical decision. The thrombophilic workup may not predict the subgroups which we need this type of prophylaxis. So our decision to anticoagulate a pregnant lady to improve the fetal outcome should not be based on thrombophilic testing. The limitations for testing is that there is no useful screen. It is not useful as a screening test because all these patients who have the defect are not going to develop venous thromboembolism. If you have asymptomatic patient, if you find out the defect, then how the individual will cope up with that test results, that there is a lifetime risk of thrombosis, how the individual cope up with that result, that's also a matter. And if you find that there is a negative result, that will give a false reassurance to the patient. But you may still develop life-threatening venous thromboembolism and the cost of testing. So the potentially, if you are decided to test the asymptomatic individual, then the cost-benefit analysis should be in favor of testing. Now, the summary of testing. The timing of testing, you should not test the patient when the patient is on anticoagulation. So the test should be done at the completion of anticoagulation for all provoked DVT. For unprovoked DVT, the test should be done after treatment of acute event only. Now, the patient is on warfarin, that it should be at least stopped at least 2 weeks prior to the testing. Newer anticoagulants like DOAC should be stopped at least 2 days or preferably longer. Heparin should be stopped for more than 24 hours. You should consider testing if the venous thromboembolism patients are younger age, or they develop venous thromboembolism with the weak provoking factors, or if there is a strong family history of venous thromboembolism, or if the patients have recurrent venous thromboembolism. The goal of testing should be the decision regarding the treatment duration, decision regarding prophylaxis in the first degree relatives, and decision regarding prophylaxis during pregnancy. These are the treatment, the testing goals. Now, so if you decide to testing the factor V Leiden mutation defect, we do an activated protein C resistance assay first, and then go for genetic testing, PCR-based assay. Prothrombin gene mutation, you go for a PCR-based assay. Protein C, you do an activity assay. Protein S, you do an antigen assay. Antithrombin, we do an activity assay. Now, the prevalence of hypercoagulable states in India, very limited data, very conflicting data. Now, this is a publication in 2013 where the pediatric patients were screened for antithrombin 3, protein C, protein S, and factor V Leiden mutations. The inherited thrombophilia was seen around 15% of studied pediatric thromboembolic patients. Now, this is a different study from PGH Chandigarh. There, the prevalence of thrombophilic conditions were 12% in around ranges from around 10 to 12% in patients who developed DVT and other venous thromboembolism. But the general population, the prevalence of these mutations were 3%. So factor V Leiden, this is a factor V Leiden study. So the factor V Leiden general population, the prevalence was 3%, and when in the DVT, the patients with DVT or other venous embolism, the ratio, the incidence was around 10 to 12%. The prevalence of Caucasian studies were around 5%. Another study which was done earlier to this study, the prevalence of general population with factor V Leiden mutation was 2.39%. So, there's another study in 2014, is done from Armed Forces Medical College. Now, they say that they prospectively studied all the 93 venous thromboembolism patients and healthy control patients with these mutation studies. What they found was in the last line, the established genetic variants of factor V Leiden and prothrombin gene mutation, they couldn't find any of these as a cause of venous thrombolism, and they posted that the established European or Western data may not be, these mutations may not be causing venous thrombolism in India. So there are conflicting reports. So current recommendation for lifelong anticoagulation is, if you have a spontaneous life-threatening venous thromboembolism, or if you have multiple recurrent venous thromboembolism, or if you have uncontrolled cancer, you are supposed to continue lifelong anticoagulation. Now, in the future, this the red recommendation may also come. Like if you have a homozygous factor V Leiden mutation, or if you have an antithrombin 3 deficiency, or more than 2 hereditary abnormality, or if you have an antiphospholipid antibody syndrome, you may continue lifelong anticoagulation. This may be the future recommendations. There are no enough data to recommend for lifelong anticoagulation in this subgroup. Now, this is algorithm for testing the first episode, venous thromboembolism. If you have a strong triggering factor, no role of testing. If you have a weak triggering factor in a young patient with strong family history, and there are female family members with childbearing age, then we consider testing for the mutation, the defects. If you have unprovoked DVT, you should consider antiphospholipid antibody testing. Especially in case of arterial or recurrent events, and if it is negative, then go for the other defects. Unusual effects, unusual sites. This is an NEGM recommendation in 2017. They say if you have cerebral vein thrombosis or splanchnic vein thrombosis, you should do the thrombophilia workup. Now, for splanchnic vein, they recommend JAK2 and PNH workup also. Now, this is actually this recommendation, this unusual site, the need of testing, thrombophilia testing in unusual site is the 2010 BJH guidelines actively discourages to test for thrombophilia in unusual sites, but NEGM paper recommends testing. So if you decide to test, you initially should have a screening panel. The initial screening panel should contain the anti-phospholipid antibody testing like PTA, PTT, anti-cardiolipin antibody assay, phospholipid anti-lupus anticoagulant assay. There should be a functional assay for protein C, protein S, and antithrombin. There should be a factor VIII estimation and fibrinogen estimation. There should be an activated protein C resistance assay, and there should be a prothrombin gene mutation assay and homocysteine mutation. This is the screening test, and depending upon the screening test, we should confirm the diagnosis by the next level of testing. Like in protein C, protein S deficiency, you should do an antigenic assay, And if there is an aptitude protein C resistance assay, we should go for a factor laden mutation analysis. And if there is an increased homocysteine, the methyl tetrahydrofolate SNP analysis. This is the second line of testing. So the guidelines say the functional assay should be used to determine antithrombin and protein C level. Chromogenic assay of protein C activity is much better than clotting assay. So that is chromogenic assay is preferable in protein C activity, and antigenic assay by immunoreactive assays of free protein S antigen is preferable to functional assay in protein S. So protein C and antithrombin functional assay is important. For protein C, chromogenic functional assay is recommended. For protein S, it's an antigenic assay, not the functional assay. Now, if you have an activated protein C resistance assay positive finding, then we may go for factor V laden mutation assay. So this is what I understood from the literature review for this talk. We can whom should we test in unprovoked proximal DVT or pulmonary embolism in young patients with low bleeding risk. Ideally, we should anticoagulate them for lifelong. If the patient wants to stop anticoagulation, we can offer the testing to them. Now, if there is a deficiency of natural anticoagulants like protein C, S, and antithrombin, there is a high risk of recurrence, so we should encourage them to continue treatment. Other mutations, anticoagulation may be stopped. And then if you have a first degree relative of unprovoked DVT, this will be the results will help in aiding, planning prophylaxis in high risk situation and in females when they undergo pregnancy for DVT prophylaxis. And recurrent DVT and life-threatening DVT, we can test to know the causes. Indian incidence, Indian data is very limited. The current recommendation to not to anticoagulate anybody with thrombophilia is based on the risk of bleeding when you anticoagulate these patients. Now, when you in the future, if you have a low bleeding risk treatment options available, then this all recommendation may change. If you find a thrombophilic condition, you start anticoagulating. It may be like that in the future. But at present, the major determinant for not treating is the annual bleeding risk by warfarin. It is expected to around 1 to 2% per year. So that bleeding risk is higher than the incidence of thrombotic risk. That's why currently the recommendation is very stringent to anticoagulate only limited conditions. And the other point is not all thrombophilics are develop DVT, and most of the thrombophilics develop DVT only when provoked by conditions. So prophylaxis during high risk event can prevent venous thromboembolism in these thrombophilic patients. Thank you.
Thank you, sir. Dr. Sriraj has done an extensive literature study to give us the best in thrombophilia testing. The audience, any queries, you can go ahead and ask. Any questions? Attendees, you can raise your hand if you have any queries too. I can unmute. Sir, like when do we call the provoked and unprovoked? This one query.
If you have a strong risk factors like you undergo a major surgery, or if you have immobilization more than 3 days, or if you have a long air travel, travel more than 8 hours, these are the provoked risk factors. Or fracture, pregnancy, OC pills, all are provoked risk factors.
When do we decide on adding antiplatelets along with anticoagulation?
Now, the current ACCP guidelines says that if you decide to stop anticoagulation for a unprovoked DVT after 3 months of treatment, the patient should be on aspirin. That's what the current recommendation. After stopping the anticoagulation, after stopping the initial treatment of anticoagulation, when you then the patients may be put on aspirin. That is what their recommendation is.
One query from thrombophilia most common worldwide and in India.
Worldwide is factor V laden mutation. In India, there are different reports, but still the factor V laden is the most common mutation in India also. Because there are, I mean, initially we were doing the activated protein C resistance assay. There are multiple stages of assay. Like there are time initially they were using a different method. There are newer methods now. So initially there were a lot of activated protein C resistance assay, but it was not confirmed by factor V laden mutation. Now currently when you test for factor V laden mutation, we are finding that we have more incidence of factor V laden heterozygous mutation.
Acute venous thromboembolism, we do not need to do the test, only after at least 3 months.
Yeah, the decision to test should start only after completion of the initial treatment after 3 months.
One query: polycythemia causing DVT. Do we start both ecosprin and anticoagulation?
So polycythemia can cause both arterial and venous thromboembolism. In our data, we see more arterial thrombosis like myocardial infarction and CVA in polycythemia. If they develop venous thromboembolism, we'll give warfarin and stop aspirin.
Any recommendation for any oral anticoagulant to start if the patient is having VT?
I think that is not my topic, but there are a lot of recommendations for the current is the chest guidelines. They recommend newer oral anticoagulants over warfarin in the acute setting. If you have idiopathic DVT, if you read that ACCP guideline, they recommend the newer DOACs over warfarin.
One more question: Is it must for thrombophilia workup for patients on chronic desmopressin therapy?
I'm not sure about that. Why is the question? Because of the high factor VIII level, resultant high factor VIII level? Is it due to
Dr. Deepak? You can unmute yourself and ask if required. Dr. Deepak? Dr. Deepak, you can unmute yourself and ask.
What I can understand is elevated factor VIII level or elevated factor IX level, they are actually a weak thrombophilic risk factor. So I'm not sure about your question.
Any more queries? You can raise your hand or you can put in the chat box. We are almost 4 p.m. So it's time to stop also. If no other queries, Sunanda Piche, one query. I think no more queries. Thank you, sir, for that elaborate and full literature review on thrombophilia testing. It was very extensive. Thank you.
Thank you, Ravi. Bye.
So tomorrow we have all others. Tomorrow we have the next talk at 2 p.m. itself. We'll be having 3 talks. So we'll be having von Willebrand disease diagnosis to management by Dr. Deepak Charles, point of care testing in coagulation by Dr. Ganesh Mohan, and rheumatology and hematology by Dr. Paul T. Anthony. We'll also be having a small talk by Dr. Joseph, our PG, who will be going through the pre-test which you have sent him. We have got only around 70 tests. We would be doing it after all the 3 sessions if we get time. Otherwise, we would be sharing the, and as per the pre-test, we might be giving a gift voucher also who gets the best mark. So thank you all. See you tomorrow.